Congenital myopathies. The congenital myopathies are a clinically, genetically, and pathologically heterogeneous group of muscle disorders defined by the presence of a particular histopathological features. They emerge as a group of disorders with a wide application of histochemistry and electron microscopy in the 1950s and 1960s, when abnormal structural defects were identified in association with a particular phenotype. Worldwide incidence of inheritable myopathies is about 14%. Hypotonia is usually present at birth or early infancy, although a rare case with hypertonia and a stiff phenotype has been reported. There are several types of congenital myopathies, including central core disease, constitutes 16% of cases, multi-mini core disease, Nemaline myopathy, 20%, centronuclear myopathy, 14%, congenital fiber type disproportion, reducing body myopathy, CAD disease, myofibril myopathies that include Desmin myopathy, hyaline body myopathy. We will discuss central core disease, multi-mini core disease, Nemaline myopathy, centronuclear myopathy, CAB disease. We will start with central core disease. It is inherited neuromuscular disorder characterized by the presence of central cores in the skeletal muscle and clinical features of congenital myopathy. The central cores are areas devoid of oxidative and glycolytic enzyme stains. The disease is caused by mutations in the skeletal muscle ryanodine receptor 1 gene RYR1 that has also been linked to malignant hyperthermia. The key word here, areas devoid of oxidative and glycolytic enzyme stains. Ryanodine receptor 1 gene, malignant hyperthermia. Clinically, typically it presents in infancy with hypotonia or in early childhood with motor developmental delay. Weakness is predominantly proximal with prominent hip girdle and axial muscle involvement. Characteristic pattern of selective muscle involvement on MRI. It means relative sparing of the rectus femoris compared with the vastus intermedius. The presence of cores in a muscle biopsy without associated weakness is insufficient for the diagnosis of central core disease. The central course may be single or multiple, central or eccentric. The key words here: the presence of course in a muscle biopsy without associated weakness is insufficient for the diagnosis of central core disease. Histologically, typically it is found in type 1 fibers. Type 1 predominance or uniformity and hypertrophy. Internal nuclei may be numerous. Myofiber necrosis and regeneration are not common. Rare cases with increased fat and connective tissue have been described. Core formation is a non-specific finding. It is also seen in denervation, metabolic conditions, in healthy individuals in following exercise, and in association with other gene defects. For example, ACTA1, MYH7. The key word core formation is a non-specific finding. These diagrams stand with oxidative enzyme NADHTR showing cores of varying size centrally or peripherally. Here, central clear zone. At the periphery, relatively normal stained myofiber. This is central clear zone, and this is peripheral, relative peripheral stained, relatively stained, normal stained. This is not TR, longitudinal section. This cytochrome, oxidase staining, COX, showing extensive areas with reduced oxidative central cores running along a significant extent of the longitudinal muscle fiber axis. This is a longitudinal section and fiber showing multiple zones devoid of oxidative activity. Also here, so the same picture, multiple irregular areas devoid of oxidative activity. But in transverse section, it can appear as single central clear zone. This is pass staining, periodic acid shift. Cores in a case of central core disease rimmed by pass staining. We see in areas that have less glycolytic activity, and also here this is a relatively normal periphery. The distinction from multi-mini core disease may be particularly difficult, as recent studies suggest a histopathological continuum between the two conditions in a subset of patients rather than distinct entities. Although great majority of multi-mini-core disease is caused by recessive mutations in the selenoprotein N gene, recessive RYR1 mutations have been recently identified in distinct subgroups of multi-mini-core disease. The product of selenoprotein N interacts with ryanodine receptor in regulating calcium homeostasis in muscle. Multi-mini core disease associated mutations give rise to clinical features such as external ophthalmoplegia, bulbar involvement, and moderate degree of respiratory impairment, which are not commonly observed in typically central core disease. These diagrams are stained with NAD/HTR, showing many small globular shaped cores in the fibers. These are areas different, small, also here, different is high power, devoid of oxidative activity. Here also, this is longitudinal sections, irregular areas devoid of mitochondrial activity or oxidative activity. Electron microscopy shows a virtual absence of mitochondria and sarcoplasmic reticulum in the core region, a marked reduction in the intermyofibrillar space, and an irregular pattern streaming of the Z lines. The most important keyword here, absence of mitochondria and sarcoplasmic reticulum in the core region. As regards treatment, no specific treatment available, only supportive care. As a prognosis, static or progressive course. Precautions during general anesthesia to avoid malignant hyperthermia. Nemaline myopathy. This is a second congenital myopathy we discuss now. Congenital myopathy characterized by the presence of nemaline rods in the skeletal muscle and caused by a mutation in the gene encoding skeletal actin. Most commonly, mutations involving the ACTA1 and NEP genes. Most cases present with hypotonia are muscle weakness at birth or early infancy. Muscle weakness is usually generalized and symmetric, with predilection for the neck flexors and sparing of extraocular muscle. The key words in Nemaline myopathy here are nemaline rods caused by mutation in the gene encoding skeletal actin. There are 6 clinical categories based on severity and age of onset. They include severe congenital form, intermediate congenital form, typical congenital form, mild Nemaline myopathy with childhood onset, adult onset Nemaline myopathy, other forms with unusual associated features. Histologically, there are dark reddish staining inclusions seen with gomoric trichrome stain. Rods are usually cytoplasmic and clustered at the periphery of the fiber. Rarely rods occur in the nucleus. Major constituent of rods and the Z line is alpha-actinin. Other components include thromomyosin, actin, myotillin, and nebulin. The most important constituent of rods is alpha-actinin. Histologically, there is marked variation in myofiber size with type 1 fiber atrophy or type 1 fiber uniformity or predominance. These are general features of myopathic changes. Rods may be restricted to type 1 myofibers. Typical myopathic features such as internal nuclei, necrosis, regeneration, and fibrosis are not common. Core-like areas may be seen on oxidative stains. These diagrams are stained with gomori trichrome stain, revealing cytoplasmic rod-like inclusions often clustered at the periphery of the myofiber. This is the periphery subcircular deposition of rods. Also here, this is high power showing the rods in subcircular deposition. Importantly, these rods are subcircular depositions. In the same idea, dark staining rods with toluidine blue. Electron microscopy revealing electron-dense rod-shaped structures that are often associated with the Z line. These are the rods. This is rods. Here rods nearby, as we notice here, nearby Z line or Z line. Also here. And you see there is early changes of Z line called streaming, which is non-specific electron microscopy myopathic feature. Nemaline myopathy can be confused with a disease called cap disease. Cap disease has the clinical features similar to those of typical Nemaline myopathy, with infantile onset of hypotonia and muscle weakness. It is caused by a mutation in TPM2. This is H&E, and this is NAD HTR. H&E and NAD HTR show sharply demarcated structure at the periphery of muscle fibers with disrupted structure. This is the disrupted area, look like cap. It look like a cap. Also here in NAD HTR, this is a sharply demarcated structure at the periphery. This is Gomori trichrome. Gomori trichrome show no nemaline rods in the cap structure in comparison to Nemaline myopathy, in which there are nemaline rods. Here we do not see nemaline rods. This is AT-base. AT-base activity is reduced. It means that there is decreased myosin AT-base activity. It means there is a defect in myosin in comparison to Nemaline myopathy, in which there is a defect in actin, skeletal muscle actin. Here a cap. This is electron microscopy. Electron microscope illustrates randomly arranged Z-line fragments associated with the thin filaments but few thick filaments. These are thin filaments in the area of the cap, and these are thin filaments, and this is fragments of Z line, and here early Z line streaming, which non-specific myopathic feature in electron microscopy. As regards the treatment, no specific treatment available. It is only supportive care, as usual in most congenital myopathy. Prognosis is dependent on clinical severity, with the most severe congenital form resulting in death from respiratory failure, and the typical congenital form following a slowly progressive or non-progressive course. Now we will discuss centronuclear myotubular myopathies. This group including centronuclear and myotubular myopathies, but they are fused together as centronuclear myotubular myopathy. It is thought that normal myofiber development and maturation is affected in this group. X-linked MTM1 autosomal recessive caused by BIN1 and autosomal dominant DNM2 variants are reported. X-linked form is linked to mutation in myotubularin MTM1 on chromosome XQ28, in which the patients present as hypotonic babies. The onset of autosomal recessive and autosomal dominant variants is generally later than X-linked form. Histologically, as in many congenital myopathies, type 1 fibers may be predominant. Most fibers are small in diameter, hypertrophic and or atrophic, particularly type 1 fibers. Increased numbers of myofiber containing large nuclei in the geometric center are characteristic. We must concentrate on more than 20%. In longitudinal section, the nuclei are regularly spaced in contrast to the chains of central nuclei in regenerating fibers. Central areas show accumulation of mitochondria and sometimes an absence of myofibrils, indicating delayed maturation or improper maturation and development. Subcircular peripheral halos are less commonly seen with oxidative enzymes. Large central nuclei in several fibers in transverse and longitudinal sections. In transverse section, note the central halos devoid of myofibrils. In longitudinal sections, there are widely spaced nuclei and nuclear chains. Most fibers are less than 10 micron. We see here, these are atrophic fibers, less than 10 micron. Here, large central nuclei. Here also we see large central nuclei. As we know, the normal myofibers are polygonal with peripheral nuclei. We see here central areas of halos indicating absence of myofibrils in the muscle at the center. This is longitudinal section, central nuclei, widely spaced, not attached to each other in cases of, in cases of regenerating muscle fibers. The diagnosis of centronuclear cytomyopathy, nuclear myopathy should be questioned if less than 20% of fibers are affected. We here also say central nuclei. This is normal. You see peripheral nuclei. This is central. We as notice more than 20%. This is central halo, indicating absent myofibrils, which is an indication of defect in muscle maturation and development. This is NADTR, NADHTR in autosomal dominant mutation, showing central accumulation of mitochondria indicated by increased oxidative activity surrounding by a halo, peripheral halo. Or it shows radiating strands of sarcoplasmic reticulum in some fibers with central nuclei. See the arrows here, central nuclei, and there is radiating strands. You here. Also in this muscle fiber, you see here. Electron microscopy. This is classical immature muscle fiber, central nuclei, no myofibril in the center. This is myofibril in the periphery, but in the center, no myofibril. Contractile filaments or myofibrils. Here we see central, this is called nuclear chain, no widely spaced. It can occur in some cases of centronuclear myopathy, similar to regenerating muscle fibers. As regard of fibers with fetal myopathy, my, fibers with fetal myosin are common in neonates, and its presence in these cases is to be expected because they are immature fibers. Labeling of myosin isoforms generally indicates that maturation, at least with regard to myosin isoforms, does occur in myotubular myopathy, and fibers with central nuclei have the fast or slow isoform of mature muscle. As regard of treatment, no specific treatment available, only supportive care as usual in congenital myopathy. Medical management generally involves efforts to prevent pulmonary complications since lung infections can be fatal. Thank you very much.